Good afternoon. Welcome to Grand Rounds. Please remember to sign the attendance record, and then please fill out the program evaluation. And if you could, give us any ideas in regards to future topics or future speakers. And actually, this topic was suggested from the audience several months ago. Today, I have the pleasure of actually introducing co-speakers, co-presenters. Dr. Kasey Strosahl, who has presented previously, and as you may recall, is a board-certified psychiatrist and the director of the Behavioral Health Unit at Mary Greeley, and other co-presenters, Lisa Barnes. Lisa is a licensed independent social worker. She has a wealth of experience in the field of behavioral health, and they have kindly accepted our invitation to present today. The title of their presentation is Moods, Party Drugs, and Seeking Help. And please join me in welcoming Kasey Strosahl and Lisa Barnes.
Thank you. So the title is just to jazz it up a little bit. The topics that we are talking about today are bipolar disorder, thus the moods, ketamine treatment of depression and suicidal ideation, and then the behavioral medicine integration program through McFarland. And Lisa will cover the behavioral medicine integration program topic. So we'll start with bipolar disorder, also known as manic depression. So bipolar disorder, this is a broad overview, are dramatic shifts in emotions, moods, and energy. So you have extreme highs, as this gentleman here on the left, and then extreme lows. So these last days to weeks at a time. So there's a spectrum of bipolar disorder. The prevalence of bipolar disorder is 2 to 4% lifetime prevalence. It is more common in women, just slightly. It's a 3 to 2 ratio. The predominant onset of bipolar disorder is in the 20s, but we do have presentations much later in life. A couple examples of that I've experienced. I had a gentleman who used alcohol as his mood stabilizer until he was in his late 50s, had been prescribed some Effexor, but wasn't taking it regularly. And then one day he decided he was going to stop drinking and start taking his Effexor 225 on a regular basis. And within the month, he became overtly manic, whereas his alcohol had given him mood stability throughout his life before. So he was in his late 50s before a manic episode was diagnosed in him. I also had a woman this year who was around 80 years old who had classic symptoms, was diagnosed with bipolar disorder. That is definitely an outlier. Generally, we don't see people diagnosed with bipolar disorder at that point in time. And even I was thinking it was due to dementia, but by the time we treated all of her manic symptoms, her cognitive scores had improved to a 20, Montreal Cognitive Assessment improved to a 26 out of 30 with treatment of her bipolar disorder. This was a woman who was going out, meeting people in the middle of the night, cooking up meals for 12 people when it was just her and her husband in the home, rearranging furniture, went and bought a new minivan, had no means to pay for that. So there are a lot of instances where they have these classic symptoms, but no known history. So bipolar depression this has the same criteria as major depressive disorder. You have to have 5 symptoms during the same 2-week time period. One of those symptoms has to be a depressed mood or anhedonia, meaning loss of interest or pleasure. And then we use the mnemonic SIGI caps for the other depressive symptoms, which include a sleep disruption, loss of interest in their activities, guilt or worthlessness, decreased energy usually, poor concentration or just being very indecisive, increase or decrease in appetite, psychomotor hyperactivity or retardation, maybe they're moving slower, moving faster, and suicidality. So mania and also hypomania. So mania is a distinct period of abnormally and persistently elevated, expansive, or irritable mood. So if they are euphoric on top of the world, those symptoms need to last a week or longer for a manic episode. If they're very irritable, the symptoms only need to be present for 4 or more days, and the symptoms only need to be present for 4 days if it's a hypomanic episode. So one of the differences is that is a distinct change from their normal mood. And a mnemonic for remembering the manic symptoms is dig fast. They're highly distractible, very impulsive, indiscretion, meaning they are going out and having multiple sexual partners, grandiosity, thinking that they have more power or abilities than they generally would, flight of ideas, increased activity, sleep deficits, meaning that they don't feel like they need to sleep, which is different from insomnia, because usually with insomnia, people feel like they need to sleep, they just cannot sleep, whereas with a decreased need for sleep, you get an hour of sleep and you're good to go for the next 23 to 40 hours. And also increased talking, usually your speech is very rapid and uninterruptible. Okay, so this is just a graph showing different states of mood. We're going from mania at the top, depression at the bottom, kind of here in the middle is just a normal mood. So and then we're going to look at mood over time. So even an average person does not have a flatline mood. Their mood changes, goes up and down throughout the days to weeks. So you can see on the graph here where mood kind of comes up and down. You have highs, you have lows, but nothing that reaches criteria of mania or depression. So an episode here where something bad happens in your life, you may be down for a little bit, but you do return to normal. Now we mix in just unipolar or major depressive episodes. So moods can still go slightly higher than normal, but there are these deeper lows that last 2 weeks or longer. Then they come back to what we describe as a normal mood. Now bipolar 1 disorder. You can still have these dramatic lows that last 2 weeks or longer, but then we can also swing into the manic episodes that, like I said, last a week, or if they're hospitalized, it could be shorter than that. Or if they are untreated, it can last months. That was the case with the woman who I saw earlier this year that was in her 80s. She had been going on that pattern for about 3 months and no one knew what to do with her. She had kept coming into the hospital for altered mental status. And then bipolar 2 disorder, similar in that we have the major depressive episodes that last 2 weeks or longer, but then the highs are much lower, but do last, as I said, 4 days or longer. All right, so psychotic features. So that's a specifier that we use with both depressive episodes and manic episodes. Psychosis includes hallucinations, mostly auditory or visual, delusional ideas. Those are fixed false beliefs, so it can be something very mundane, or it could be something pretty off the wall. So if someone is experiencing a hypomanic episode and you think they have psychotic features, they are not having a hypomanic episode because you cannot have hypomania with psychotic features. Mixed features. So patients that have bipolar disorder in a mixed episode are some of the most distressed patients you'll see. They have concurrent major depressive episode as well as mania or hypomanic symptoms. So they're often having the decreased need for sleep, but they're also usually very depressed. They're usually pacing around, and they just have symptoms that are classified as that major depressive episode and as manic. they're also more likely to attempt suicide during one of those states, because one of the things that we see with depression is once they've started treatment, once their energy improves, they then have the energy to plan and proceed with a suicide attempt, whereas in a mixed episode, you have all of that energy already and you're already feeling terrible. So there are other disorders to consider when considering bipolar disorder. Other things on the differential would be ADHD, a substance-induced mood disorder, anxiety disorder, and personality disorders. So there are several screening tools out there. There aren't that many diagnostic tools. Some of the ones that are commonly used is the Mood Disorder Questionnaire. Again, this is a self-report instrument used by the patient. And it's, again, a screening tool, not a diagnostic tool. The CD, which is clinician administered, but again, it is a screening tool. The SCID is the gold standard for diagnosing. It's used in research protocols, but it's not commonly used in the clinical setting. So I've just included the Mood Disorder Questionnaire. I'm going to ask many of the questions. The problem with the Mood Disorder Questionnaire, I feel, is that it's very nonspecific, and you get a lot of other diagnoses included in there. The CD is better, but still, again, it's just it's a screening tool. The first stem is euphoria. So if you get the euphoric manics, the patients who feel like they're on top of the world. And then there's an irritability stem, because some patients are just very irritable when they're manic. And then there's other screening questions, and those screening questions make sure that the symptoms that they're experiencing is all during one time frame instead of multiple different periods of time, which the Mood Disorder Questionnaire does not specify. So there are other questions that need to be asked if you think that someone is, that they could have bipolar disorder. So asking how long the manic or hypomanic episodes last is very helpful. If they say that their episodes last a few hours or up to a day, that's more suggestive of a personality disorder than bipolar disorder. If asking how frequently the manic or hypomanic episodes occur. If someone says they happen daily or several times a week or even weekly, those are uncharacteristic of bipolar disorder as well. Asking whether those hypomanic or manic episodes have occurred only when drugs are being used is helpful. Someone that's high on meth certainly appears to be manic. We have sometimes the difficult job of trying to parse out which came first, the substance use or the manic episode. We have patients who don't use substances until they start to get manic, so they start to have that impulsiveness and indiscretion, and then they start using meth, and then it really skyrockets their manic symptoms, but they were already manic before that started. So it's trying to parse out which happened first. Trying to figure out how many depressive episodes have occurred. A high number of depressive episodes is indicative of bipolar disorder. So a family history of schizophrenia or bipolar disorder also indicates a higher likelihood of developing bipolar disorder than if someone only has a history of depression or major depressive episode in their family. If asking if they've been previously diagnosed with bipolar disorder or schizophrenia can be helpful. Some people like to self-diagnose with bipolar disorder and tell you they've been diagnosed, and then it's really usually more indicative of borderline personality disorder. So trying to figure out who you can get information from that made that diagnosis is helpful. The response to antidepressants can be helpful with diagnosing bipolar disorder. Some people with bipolar disorder start to experience hypomanic symptoms when they're given an antidepressant medication, whereas some patients with bipolar disorder have absolutely no response in any of their symptoms to an antidepressant. So treatment options, as far as medications go for bipolar disorder. So there are several medications out there. I'm just going to talk about the most common ones. The big three mood stabilizers are lithium, valproic acid or Depakote, and carbamazepine. Lamotrigine, Lamictal, is also used, but it's a maintenance treatment of bipolar depression. It does not help with manic symptoms. So if someone has extreme manic symptoms, lamotrigine is not going to hold them from having a manic episode. Antipsychotics are also commonly used. Sometimes if someone does not have good insight into their illness, they will only be on an antipsychotic medication because it will need to be an injectable antipsychotic. Ones that are commonly used for bipolar depression are lorazepam, olanzapine, quetiapine, and cariprazine. Those are the only ones with an FDA indication. Any of them can be used. Those are just the ones that have the FDA indication. The last one is Vraylar, and that was only newly approved, I think, last week or the week prior for depressive episodes. So what was not mentioned was antidepressants. That's because they are usually used in treatment of maintenance of bipolar depression rather than acute treatment of depressive episodes. And there's very little evidence to support that they are helpful in treatment of bipolar depression. Bipolar depression is one of the more difficult depressions that we come across to treat. Other options are psychotherapy. I'm not saying that you could use psychotherapy instead of medications. It's just a second treatment. Psychotherapy increases the symptom control. It decreases the risk of relapse. So there are very specific things that you can work through, encouraging medication compliance. I would say males in their 20s with bipolar disorder are some of the most non-compliant people I've ever met. Psychoeducation involving their family, relapse strategies, establishing a regular sleep-wake cycle, and then working on their interpersonal relationships. So some of the utilities of psychotherapy is learning their symptoms and how to identify those, and involving people in their care that can also recognize those to get them to a higher level of treatment faster. And that may just mean seeing their mental health provider to have a medication change before they need to land in the hospital. So no one wants to be in the hospital, and sometimes if we can catch those symptoms early, we can avoid being in the hospital. So bipolar disorder is very important. It's the 6th leading cause of disability, according to the World Health Organization. There are lots of different impacts. There's a high risk of suicide in bipolar disorder. 25 to 60%, which is a huge range, will attempt suicide at least once in their lifetime, and anywhere from 1 in 5 to 1 in 20 will complete suicide. The difficulty with bipolar disorder is their suicide attempts are much more lethal. They have a 3-to-1 ratio of attempts to completed suicides, whereas the general population is a 30-to-1 attempt to completion ratio. The life expectancy of someone with bipolar disorder is 10 to 20 years less. That is mostly due to chronic medical issues, sedentary behavior, obesity, tobacco use. I'm not sure if many people know this statistic. Up to 70% of people with bipolar disorder smoke. Up to 85% of people with schizophrenia smoke. So that's a huge comparison to the general population, whereas at most 25% of the general population smokes. All right, ketamine. So is it the next best thing, or is this a nightmare waiting to happen? So I think, so what I'm going to present is some of the literature that's out there. There's not a ton of literature, but I'm going to go through it so that way you can draw your own conclusions about ketamine. So ketamine was first synthesized in 1962, first used in humans in 1965. It's a field anesthetic used during Vietnam War initially, and the uses have expanded. It's commonly used, especially even in our emergency room, for agitation in the emergency setting, treatment of chronic migraine headaches, treatment of status epilepticus and pain treatment. So in the 1970s, it was widely used as a recreational drug, and there's still areas of the world that it is commonly used as a recreational drug. It's commonly closely associated with club drugs such as Molly or ecstasy, GHB, methamphetamines. And most of it is obtained by diversion because it's difficult to make. Structurally related to PCP, so it is hallucinogen, and dissociative anesthetic and hallucinogen properties. It primarily acts on NMDA receptors, but it does have some opioid receptor activity and sympathomimetic properties. So this is one of the first studies. This was a research article that came out in 2017. It was just a survey of clinicians that are using ketamine in their clinical practice to see what they were using it for, how they were using it. So the diagnoses being used were major depressive disorder, bipolar disorder, and PTSD. So it's been used IV, oral, and intranasal. The dosing IV was 0.5 mg per kg over 40 to 45 minutes, in a range of doses, though anywhere from 0.5 to 3 mg per kg. So there are several things that they monitored, but there was no specific monitoring parameters that they followed. The frequency of the maintenance treatments were also variable from monthly to less than monthly, every 2 weeks. And most of those patients were paying out of pocket for these treatments. 64% had to pay out of pocket. 23%, a portion of the treatments were covered by their insurance, and there was some with another payment structure. All right, so this is ketamine for the rapid reduction of suicidal ideation and major depression. They did use a comparator drug. They used midazolam. So this was a study involving only 80 adults, which is actually a pretty big trial for ketamine with 80 patients. They had major depressive disorder. So they found that the suicidal ideation was lower in the ketamine group compared with the midazolam group at day 1. The suicidal ideation largely, the elimination of suicidal ideation was largely maintained over the course of 6-week follow-up. But the response rates for depression were surprisingly low. So although it acted on their suicidal thoughts, it did not necessarily improve their depression. So in the same trial here, they found that the number needed to treat was 4, but it did have adverse effects on blood pressure and produced some dissociative symptoms. So out of those 80 people in the trial, 10 of them had adverse events. 2 were for unrelated medical illnesses. 1 was for sedative misuse, so ketamine misuse. There were 4 suicide attempts, 3 inpatient admissions for suicidal ideation, and then there were 2 suicides that occurred after the completion of the study. Moving on to our next trial, so this so this was the effects of the ketamine clinician-administered treatments. So there were a greater proportion of patients free from suicidal ideation. The number needed to treat was 3 to 4 at time points 1 to 7 days after ketamine infusion. Whereas on the self-report measures, number needed to treat was 3 to 5 for 1 to 3 days after infusion, but the number needed to treat was 10 at 7 days. So there was some worsening of suicidal thoughts even over the course of 7 days here. So the durability of the effect. So there were effects that persisted in 86% of those who received ketamine in the clinician-administered measures. 53% of patients who received the controlled treatment still had remission of symptoms. So what you'll notice in psych literature is there's a really high placebo rate, and so don't attribute everything to a treatment. So the conclusions here were that ketamine does reduce the suicidal ideation, at least one day, if not longer, but the suicidal thoughts and the depressive symptoms are not well correlated between those two. So they suggested that the further investigation needed to be on ketamine's effect on suicidal ideation beyond 1 week, the effects on the suicidal behavior, because that was not measured, possibility of rebound suicidal ideation, and then the exacerbation of psychotic symptoms in those prone to psychosis. This was a nice review article in Focus, which is a CME psychiatry journal that came out in 2018. So they just did kind of a review of all of the literature available. So they noted that there was very little research attempting to identify the optimal dosing strategies of ketamine. Most people use the 0.5 mg per kg IV based upon the effects on cognition and perception, but there is no optimal dosing. They do know that there's a dose-response relationship, but they don't really know what it is. Most of the randomized controlled trials have used single doses of ketamine, and there's always a near complete relapse of symptoms when followed for extended periods of time. Several case reports suggest that antidepressant effects can be sustained for months with repeating the ketamine, but there's little high-quality controlled data published to demonstrate the sustained effectiveness of ketamine. And again, the optimal route of administration is unclear, whether it's IV, intranasal, subcu, or oral. There are risks of using ketamine long-term. So there are long-term effects on cognition, perception, and anxiety levels, as well as chronic cystitis, hepatotoxicity, gallbladder pathology, impaired cognition, persistent dissociative effects, and also the ketamine abuse and dependence. So the conclusions that they drew, that there were still many unanswered questions and concerns related to ketamine's use in clinical management. They know that the mechanism at some level involves neuroplastic change that extends beyond the presence of the drug in the body. Again, there's little high-quality data to base optimal dose, route, and frequency, and there's no data really on the longer-term benefits of using ketamine. There are a lot of ethical challenges with using ketamine for depression treatment as well. So this is one article that I found rather interesting. So the article is Attenuation of Antidepressant Effects of Ketamine by using an Opioid Receptor Antagonism. So basically what they did was they don't think that ketamine's effect on depression is related to its NMDA receptor antagonism. They thought that maybe it was related to its opioid receptor antagonism. So what they did was treated patients with naltrexone 30 minutes before the ketamine infusion, and what they found, so this was a double cross, it was a crossover trial, so there were only 14 in the study, and 12 completed the crossover. So it's a very small study. But what they found was that the patients who received naltrexone before the ketamine infusion did not have a depression response to the ketamine infusion. So you'll see the top bar here, so this line is those are the scores, depression scores for someone that received the naltrexone before ketamine, and this is someone that did not receive naltrexone before the ketamine, that had placebo. So clearly there is an opioid response for depression in using the ketamine. right, so they found that it worked through the mu opioid receptor. And so the abuse problems are then what you're looking at. So if this acts on an opioid receptor, we're already having problems with opioids around the world. And opioids, ketamine abusers have a higher rate of depression and experience brain dysfunction. There are case reports that people have tolerance to ketamine after several infusions. So basically this article was cautioning against widespread use of ketamine to treat depression because the mechanism from what their early studies show is that it acts on opioid receptors. All right, so S-ketamine, also known as Spravato, was approved in March for refractory depression, so that's intranasal ketamine. It was the first novel treatment of depression since Prozac was introduced in 1987. So there's a lot of medications that we have in psychiatry, none of them are novel. So the S-ketamine has to be used in conjunction with an oral antidepressant. It has to be used in treatment-resistant adults. So they have to have a trial of at least 2 antidepressants, and it's not to be used for mild depression. There's a black box warning, not surprisingly, for risk of abuse and misuse. And there's a black box warning. The REMS program. Like with clozapine, we have a REMS program, so that way it's only being distributed to people that are qualified to do that. And the S-ketamine has to be administered under supervision of a healthcare provider in the office of a certified physician. And they have to be observed for at least 2 hours after the administration. So again, this article cited that there are still many unknowns about the long-term effects of the ketamine. And there are still these huge knowledge gaps about efficacy, tolerance, and side effects. Other thing to know is the cost. So it's not clear how much insurance is going to cover. So dosing can either be 56 milligrams or 84 milligrams, depending on what the clinician decides. So the cost of the first month is $5,000 to $7,000, and then there's maintenance treatment. So again, pretty costly. So sweeping conclusions about ketamine. So there's IV treatments being done around here. There are the S-ketamine, the intranasal clinics being set up for treatment, suicidal ideation, major depressive episodes. It's not for mild depression, so this should be people that have refractory depression. Again, there's no research that demonstrates what the dose should be, what the frequency should be, and we don't know the long-term effects. So this could end up making their depression worse. It could make their cognition much worse, and they could become dependent on it. And it could be costly because the insurance may not cover it. So I'll go through. Now we'll move on to Lisa's part.
Thank you for inviting us here to talk. One of the great privileges of being part of this new rollout program of behavioral medicine is working with Kasey Strosahl and our team together, and this whole team here that has helped with the rollout of this program. I'm going to be talking initially about, I'm Lisa Barnes. I'm going to be talking initially about the behavioral, there's 2 components of this program. One is the behavioral medicine, the integrated behavioral health, and the other is what we're doing together with collaborative care. So, is it up? Good. The often quoted statistic is that 1 in 6 of us will experience mental illness at some time in our lives. We have the opportunity here to screen and provide services for people whose mental illness is activated, who have a history of mental illness, and to help with prevention of mental illness. This is primary care and it's primary prevention in so many ways. It's through the visionary leadership of Dr. Skinner and the administrative team, which includes physicians, that this program was developed. And behind the scenes, I'd been courting this job for about 6 years, so I'm very pleased to have it and to be of service in this way. It's also, so I'm the front person, but right beside me is a whole team that is helping with the program, support in developing it and supporting it. So Emily is the EPIC coach who has been very patient with me. Sally is the billing supervisor helping with coding with Kara and Kim, and this is something that we're continuing to work on so that as many services as possible we can be reimbursed for. Austin is our analytics guru, and we are now working more on population health, and Jennifer is his MIS EPIC assistant who's helping also with the screenings and how we are measuring the populations around the screenings that we're using. Elizabeth has been our EPIC person who has rolled out the workflow for behavioral health. EPIC itself, the big EPIC in Verona, Wisconsin, does not yet have a integrated behavioral health workflow, and so she's developed that. They may want to buy it from us, but she's developed it. And she's also developed the workflow for collaborative care, which is a new Centers for Medicaid and Medicare program. And again, there weren't workflow developments, so we have it now because of Elizabeth's skill and expertise. Why we're doing integration, the lifestyle, the things that we can change really vary in terms of the percent. I found this slide. And this is the area that is growing most in terms of our science. We're learning so much more about the impact of our health on traumatic events in our adult lives, as well as adverse childhood experiences, and how our brains process pain as well as other events. Really interested in community health impacts also on our health. So this is the intersectionality that I'm working in, depending on the patient's presenting concern. I'm very interested in sleep, quality and access to healthy food, value in movement. Where's Dr. Bird with the healthy food? Is he in here? History and intentions for well-being, and what brings joy and meaning and purpose to people's lives. That's all in the first 45 minutes when I meet with someone. Subsequent visits are 30 minutes, and I tell people that this is not like what I did when I was a traditional therapist in meeting with people for 50 minutes ongoing. I meet with people intermittently and repeatedly, whatever is needed for them, and our focus is on interventions which support their health and well-being, and that's quite broad. All of us need interventions to help with our health and well-being. I'm an active member of an integrated behavioral health professional organization called the Collaborative Family Healthcare Association. And this organization has an annual conference, supports research, has bi-monthly journal, listservs, which I've passed on to some other people, and provides technical assistance. This is some data from some research that has been done about the impacts of integration. It meets the triple aim. Oops, I think I skipped one. So out of this Centers for Medicaid and Medicare, SAMHSA, and this organization have identified layers of integration. Probably when this clinic started integrating or providing behavioral health services, it's before my time, 15 years ago maybe, that was more co-located. It was behavioral health that had offices here, and they were located within the McFarland Clinic structure. What we are doing now is very different than that. This is not co-located, this is integrated. So I'm on the EMR with all of you. We collaborate with each other daily and sending notes to each other behind the scenes, and also working to the benefit of the patients. The other piece about integrated behavioral health is we are looking at population health. The spread is much greater than just meeting with individuals and providing the supportive therapy services. We're looking at ways that we can capture data that help us do our jobs better and provide greater spread with what we're doing. So the next thing that I wanted to talk about is our collaborative care Dr. Strosahl and I are doing together. This, again, is a Centers for Medicaid and Medicare rollout. And this is rolled out because we have such a dearth of psychiatry across the country that we need to be able to serve people with psychiatrists in primary care. It's very hard for people to get in to see a psychiatrist. I don't think I need to tell all of you that. So the healthcare provider will refer a patient, and what we've done is they refer the patient to me. I do some extra layers of screenings and conversation, and then refer the chart to Dr. Strosahl. She and I meet when we're both in town on Fridays, and we review all the charts that I've sent her during the week. Providers can also specify, I'd like to have a psychiatric consultation, and I read that in the notes. So those charts, with patient's permission, are sent to Dr. Strosahl. She and I review the charts, and then she spends the rest of the day writing these incredible consultation notes to the providers. So she does not see patients directly, nor does she prescribe directly to patients. The providers, you as providers, receive those consultation notes, and often there's different layers of if this works or doesn't work, then use this. So that's up to you and how you use that information. She and I attended an Iowa Psychiatric Society seminar, half-day seminar in the early spring, and we are the only clinic throughout Iowa that is incorporating this into our program right now, that we know of. And there were a number of psychiatrists at that meeting. People are interested in it, but it's not happening in other practices yet. So we hope that as we refine it, that we can help other clinics through our presentations be able to use this model. This next couple slides, so the collaborative care model is, there's a couple things that we're not doing, but we're working on doing. One of them is that we don't have a care manager. So right now I'm providing that care management also to patients who receive the consultation. And that's weak in having time to do those follow-up calls. But it helps when we do. And providers can help with that also by following up. We are asking that all the referrals come through behavioral health, because then it helps us do our jobs better, that Dr. Strosahl has the screenings. And just to reiterate, she doesn't see the patients directly or prescribe to the patients directly. This is some of Austin's genius in looking at some slides. And this one is about just number of patients per month, and you'll see on the top one that unique patients went down. That's because I'm carrying more people that I see regularly. So it doesn't mean I'm seeing less people. It just means that they're not all the new patients coming in. And this slide may be a little bit misleading. How we document our time, I'm documenting my time on Dr. Strosahl's encounter, because that's how this is billed. So much of what we're doing is legal, but it's morphed in some ways with the documentation so that we'll make sure that it's billable encounters. Does that sound okay, Sally? Okay, thank you. This is a slide that I'm really interested in, and we just got this data recently at our meeting with Austin and Jen. So when we have a PHQ, which is the depression scale, and we have a follow-up after a patient has been touched by behavioral medicine, this is showing that there's an improvement. The depression scale has been lowered. Now the numbers are really small because we're not intentionally doing the follow-up screenings. It just happened that there were some. If we can capture this data and some other data, then we have an opportunity to impact one of our payers that is not now paying for valued care. So this is an area that we can do significant improvement. I have started measuring, using the GAD also, in measuring anxiety, and we'll try to do measures after I see patients also. So if we can capture those changes, it's a great opportunity to be able to have greater service because of payment. The other piece about this is that screenings, when I do the screenings, they're not billable. When providers do the screenings, they're billable under E&M codes. I'm not billing E&M codes because the psychotherapy codes pay greater than the E&M codes, if that makes sense to any of you providers who are in the office. So it's something we may need to look at in terms of the screenings. And the last slide. So why are we doing this? Is it making a difference? We're capturing what we can with billing. We're also looking to measure population health, and that helps give us information for changes. We hope that we're supporting primary care providers in what you do by providing this behavioral health service and contributing to the culture of compassion by having one other service to support patients with what their needs are. I'm struck, I really like people's stories, and I work with people who automatically tell their stories of what's wrong with them, about their illness. I work with them also to have a story about their health. And it's just by raising questions and looking at resilience, how they've overcome difficulties and what resilience they have. I'm also very interested in tipping points for change. Since I've been doing this over 30 years, it's one of the things I listen for. What is it that helps people mobilize into an open mindset and make changes? Or as Melinda Gates has coined in her new book, that moment of lift. So I often document that in my notes so that you can see that also. Any questions for either Dr. Strosahl or me? Oh, thank you. Okay. So thanks. I appreciate that prompt. It's in my notes, but I didn't read it. If we were to look at PHQ-9 scores of 15 to 20, which is in the moderate to severe range, of all the McFarland Clinic patients, there'd be 1,431 patients who have scores in that range. We have an opportunity to serve people who experience moderate to severe depression if those people were referred into behavioral medicine department. And those patients who score 20 or more, which is in the severe range of all McFarland patients on their PHQ-9s, those patients would be 581. So that's a captive audience of people who certainly could benefit from services. Any other questions or prompts? Thank you.